All right, everyone, we'll go ahead and get started. Again, my name is Gabriella Grause, and today I'll be presenting on telemedicine. So first, we're going to start with the Kansas statutes and regulations, and I'm going to go into what they looked like before COVID and how they changed after COVID. And then again, we're going to do the same thing with the Missouri statutes and regulations, followed by the federal requirements and how COVID impacted and changed those requirements. And then we'll wrap it up with things and steps that you should take going forward. So like I said, first we have our Kansas statutes and regulations before COVID. And the Kansas Telemedicine Act was last amended in July 1st, 2019. And maybe it's just the young associate in me, but I put up this slide specifically addressing definitions because I think it's really important. It will give us our guidance as far as how broad or how narrow the statutes are and who it applies to, what providers it applies to, and the definitions for the sites. So they'll be different between Kansas and Missouri. So first, under the Kansas Telemedicine Act, it defines distant site as the location where the provider is, while the originating site is the location where the patient is. And healthcare provider is under this act before COVID is relatively narrow, and it is only physicians, licensed PAs, licensed APRNs, and those that are licensed, registered, certified, or otherwise authorized by the Kansas Behavioral Sciences Regulatory Board. And it defines physician as a person licensed to practice medicine or surgery by the Kansas State Board of Healing Arts. Telemedicine is also referred to as telehealth, so they're used interchangeably under the Kansas law. And as you can see, the definition is up there. And this includes secure video conferencing or store and forward technology that facilitates the assessment, diagnosis, consultation, telemedicine, education, and care management. So under the Kansas Act, this does not include communication between healthcare providers that consist solely of phone calls, or so voice only phone calls, or email or fax. And it also does not include physician and patient communication via email or fax. Then the Kansas Telemedicine Act addresses patient privacy and the patient-provider relationship. So under the Kansas Telemedicine Act, the HIPAA requirements are the same for services that are provided in person versus services that are provided via telemedicine. And it makes clear that even if you're providing services via telemedicine, you may establish and you should establish a valid provider-patient relationship. Again, same standards of practice and scope of practice and conduct for providers applies to telemedicine services as they do for in-person services. This will be pretty much a consistent theme throughout this presentation, that you should treat the care that you're providing the same for telemedicine as you were for your in-person services. You must provide patients with guidance regarding their follow-up care. And the last example is, this is when a patient consents and then also has a primary care physician or a treating physician. You as a telemedicine provider should send the primary care or treating physician a report within 3 business days of the treatment or services that you rendered to the patient via telemedicine. However, that last requirement, providing notice to the patient's treating physician, does not apply to persons licensed, registered, certified, or otherwise authorized to practice by the Kansas Board of Behavioral Sciences, the Behavioral Sciences Regulatory Board. So they're not subject to that, but otherwise, if you're licensed by the Kansas State Board of Healing Arts, you're going to need to provide that report to the treating physician with the consent of the patient. So next we have the applicability, and that first bullet point shows you that it applies to pretty much everyone. So it's Medicaid and commercial payers. And it specifies that they cannot refuse to cover an otherwise covered healthcare service just because it's provided via telemedicine. Again, they can treat payment and reimbursement the same way that they would treat it for inpatient services. So like I said, our common theme, it's back again already. Treat telemedicine services generally the same way that you're going to treat inpatient services. And I think that's like a pretty good rule to fall back on if you're questioning how to do something via telemedicine. Finally, the Kansas Telemedicine Act specifically says that nothing in the act should be construed to authorize an abortion of any kind via telemedicine. So here we have the regulations to the Kansas Telemedicine Act, and it's simple and straightforward. Basically, it's exactly what you get from the statute. The definitions are the same. Again, always go to your definitions first. And it provides a little bit more with 177.2-2. Delivery of healthcare services are deemed to occur at the originating site, which again, going back to our definitions, is the location where the patient is. And then finally, I sound like a broken record, but the same laws and regulations that apply for prescribing medication, including controlled substances, for inpatient or in-person services also apply for telemedicine services. So now we have our Kansas statutes and regulations after COVID-19. So we all remember, thanks to Gary's chronology earlier, of how it all started. January 2020, nationally, we're kind of all getting an idea of what was happening. And then February, March kind of came to Kansas. And so over a year later, Governor Kelly signed Senate Bill 283. And the goal was to ensure that Kansans can maintain pandemic-related provisions that increase their access to healthcare. So specifically, this expanded the use of telemedicine in response to COVID-19. And this will last until March 31st, 2022, which really, when you think about it, is not that much longer. It's about 5 months that we have left, 5.5. And it also, Senate Bill 283 also amended statute 48963, which we'll address on the next slide. And it addresses telemedicine specifically after COVID came along. Again, definitions. This statute, so this is after COVID-19, it states that telemedicine, it's a little more of a broad definition than the Kansas Telemedicine Act, but it defines telemedicine as the delivery of healthcare services by a healthcare provider while the patient is in a different location. And it defines physicians as a person licensed to practice medicine and surgery. And that is the same definition as before. Unlike the Kansas Telemedicine Act that addressed healthcare providers, this statute specifically addresses what physicians can and can't do when practicing telemedicine. So first, we start with it allows physicians to issue prescriptions for even for controlled substances without an in-person examination. So we realize COVID is strong, and we're going to allow physicians to prescribe even if they're not seeing the patients in person. They can even prescribe or practice if the physicians themselves are in quarantine. That includes even if it's like self-quarantining, even if they don't have COVID. And then the next thing that it addresses is that even physicians that are licensed out of state may provide telemedicine services for Kansas patients, but they must hold a temporary emergency license, which we'll address later. And it also, the statute gives the Kansas State Board of Healing Arts the authority to extend the healthcare professionals that are that can apply for that temporary emergency license. And I'll address it, but it's evident on the emergency waiver license application that they extend it. It's available for more than just physicians, but the Kansas State Board of Healing Arts hasn't passed a statute or a regulation that specifically extends that definition of healthcare providers. So it's a little unclear if that's official or not. Finally, physicians, when practicing telemedicine, they, under COVID circumstances, they must conduct the appropriate assessment, evaluation, and documentation of the patient's condition, even if it's services provided via telemedicine. So next we have the Kansas Telemedicine waiver. So this is what I was talking about when the statute that gives the Kansas State Board of Healing Arts the authority to expand on the healthcare professionals that are eligible for the waiver. You'll notice if you look at the waiver application that it gives a long list of the healthcare professions that are regulated by the Kansas State Board of Healing Arts. So this includes athletic trainers, independent certified midwives, chiropractors, doctors of medicine and surgery, doctors of naturopathic medicine, doctors of osteopathic medicine and surgery, pediatricians, licensed acupuncturists, occupational therapists, occupational therapist assistants, PAs, physical therapists, their assistants, radiologic technologists, and respiratory therapists. So just based on the application, it applies to a lot of healthcare professionals. But like I was saying, they haven't released any regulations that specifically expand the definition of healthcare providers. So that's where some of the gray area comes in. To apply for the telemedicine waiver, you do not need to hold a Kansas license. So this is for non-Kansas practitioners and providers. So basically, if they qualify and if they apply and are accepted under the waiver, they are going to be subject to all the rules and regulations that are applicable to the practice of their licensed profession in Kansas. They're basically going to be considered a licensee under the Professional Practice Acts, and they're basically going to be considered a Kansas licensee without actually being a Kansas licensee. So they're going to be subject to all the same statutes and rules and regulations that our Kansas providers will be. So the requirements for applying and being accepted under the telemedicine waiver is that they must hold a full, active, and unrestricted license in another state, and they must meet the Kansas qualifications for their profession. And they must not be subject to any investigations or disciplinary actions within the applicable licensing agencies for their profession. So now we have the Kansas statutes and regulations before COVID-19. So this is like Kansas's KAR 40-2213, their applicability statute. And it states that health carriers and health benefit plans cannot deny coverage for something that would otherwise be covered simply because it was provided via telemedicine. Again, they can't exclude services just because they were provided via telemedicine. These health carriers and health benefit plans are not required to reimburse for site origination fees or costs, but they must reimburse for telehealth services on the same basis as in-person services. And then finally, they cannot impose on beneficiaries any co-payment, co-insurance, or deductible amount or other limitation that is not also imposed upon all other policies, contracts, or health benefit plans. Again, just don't treat telehealth services differently then you would treat services that are provided in person, and you can't bill the beneficiary more than you would under normal circumstances. Which also the last bullet point basically addresses the same thing. Before it's specifically addressing the beneficiary, but the last bullet point is saying that the healthcare services can't be subject to any greater deductible, co-payment, or co-insurance amount. So again, look at our definitions. They're going to be different under the Missouri law. So the Missouri definition of healthcare provider is broader than Kansas's definition, and it defines healthcare provider / professional as a physician or other health practitioner licensed, accredited, or certified by the state of Missouri. So again, that was under the Kansas Telemedicine Act. It was physicians and providers, and then those that were licensed by the Kansas state, the Kansas, I can't think of it, the Behavioral Sciences Regulatory Board. So it's more narrow. The Missouri definition is more broad. And again, telehealth services they're subject to the same scope of practice and the same standard of care as in-person services. However, here under the Missouri statutes, the healthcare provider must be fully licensed to practice in Missouri to engage in telemedicine services. This is before COVID-19, but we don't see any further Missouri statutes or regulations that change that. There are a couple exceptions to this, however. The requirement that they have to be licensed in Missouri to provide the telemedicine services. So if there's an informal consultation outside the context of a contractual relationship, it's irregular or infrequent, and there's no expectation of compensation, or there's an emergency or disaster, and again, there's no payment made. So in those first two exceptions, it's basically, this is not a normal thing. This is not what usually happens, and we're not expecting payment. And then in the last exception, it's just an episodic consultation by a provider that is in another state on the request of a Missouri physician. So these are the exceptions, and basically just goes to show that they're not the norm for people licensed outside of Missouri to be able to provide telemedicine services inside of Missouri. So next we have the Missouri statute that addresses the practice of telehealth rules and definitions. So it states that the Missouri Department of Social Services will be the one to reimburse providers for the services that are provided via telehealth. And again, the same standard of care must be met in order to receive that reimbursement. DSS is not going to restrict the originating site through rule or payment if the provider can ensure that the services meet the standard of care. So again, it's going to be treated as if it's in person, but you just need to be able to prove that you met the standard of care, regardless of the fact that it was provided via telemedicine. The payment will not depend on a minimum distance, minimum distance requirement between the originating site and the distant site. And then finally, the Department of Social Services reimbursement shall be the same as for in-person contact. However, consideration will be made for reimbursement to the originating site. So they will take into consideration the originating site, which is the location of the patient. That last point, though, does not apply when the services are provided via asynchronous store and forward devices, which the statute defines as the collection of a patient's relevant health information and the subsequent transmission of that information from an originating site to a healthcare provider at a distant site without the patient being present. So next we have the statute that again basically says that prior to prescribing any drugs, it includes controlled substances, there must be a valid provider-patient relationship. And remember, this is pre-COVID, so in order to do so, the Missouri statutes require that that the provider obtain a reliable medical history and physical exam of the patient, that they have a sufficient dialogue regarding the patient's treatment options, that the provider schedule and provide guidance to the patient regarding follow-ups, that the provider maintain a contemporaneous medical record of the patient, and finally, that the provider maintain electronic prescription information of the patient's care. And a valid provider-patient relationship may be satisfied by the physician's designee in these instances, and the statute gives the instances in which a physician designee may satisfy the requirements for the physician-patient relationship. As you can see, if it's, a hospital, hospice program, I'll let you read the rest. And so then next we have the statute that says that to prescribe any drug based solely on a telephone evaluation. So it must be within the prescriber's scope of practice, and the prescriber, the provider, must have a previously established and ongoing physician-patient relationship. So this is different than what we think of telemedicine, because it's just over the phone. It's a telephone evaluation versus a video type telemedicine visit. You're not seeing the patient. So that's why they have these. It must be within the scope of practice, and they must already be a patient. So this statute states that APRNs that are working under a collaborative practice agreement, they may provide services outside of the geographic requirements if the collaborating physician and the APRN are utilizing telehealth, and it is the services are being provided in a rural area of need. So the Missouri statute defines rural area of need as any rural area in Missouri which is located in a health professional shortage area. So they're not going to take away that geographic proximity requirement unless it's located in a health professional shortage area. Again, even though they're letting the APRNs and the collaborating physician utilize telehealth, they must still obtain patient consent, and they must still ensure a confidentiality of medical equipment or medical information. So then we have the Missouri regulations, and if you couldn't already tell, I feel like Missouri has a lot more like random statutes and regulations that incorporate telemedicine or address telemedicine, and this is kind of what this list of regulations is. But level 3 and 4 stroke centers must have regional networking agreements with level 1 or level 2 stroke centers, so that the level 1 and level 2 stroke centers will provide telephone consult or telemedicine consultation, and it must be available for the level 3 and level 4 stroke centers within 15 minutes of notification of a stroke patient. So that basically needs to be set up so that if there is a stroke patient, they'll have that telemedicine consultation within 15 minutes, which is a pretty quick response time. And then under the next regulation, level 3 and 4 STEMI centers must have a regional networking agreement with the level 1 or level 2 STEMI centers for the same type of telephone consult or telemedicine consultation. And it doesn't provide a specific time period, but it just says it needs to be promptly available. So they're expecting that type of arrangement between these types of centers, that they can have that assistance and support from those higher level centers. And then finally, psychiatric and substance use disorder treatment programs must use telemedicine in accordance with the federal confidentiality regulations. So just because it's via telemedicine doesn't mean that HIPAA and federal confidentiality regulations go to the wayside. They must be implemented and ensured. So next we have the prospective patient hospital services reimbursement methodology. And basically it states that the costs and charges for the telehealth originating site fee reimbursed on a fee schedule shall be excluded when calculating the outpatient cost to charge ratios used to determine outpatient percentage rates. And this starts with the calculation of the outpatient percentage rate for the state fiscal year after telehealth originating site fee is moved to a fee schedule. And this was passed July 30th, 2019, but it was effective January 1st. It was last amended July 30th, 2019, but it was effective January 1st, 2019, that telehealth originating site fee is paid at the lesser of the billed amount or the outpatient fee schedule amount. So next we have the regulation that defines telehealth. This is more broad than the definitions that is used in Kansas. Basically, it's using the use of medical information exchange from one site to another via electronic communications. It's just not as specific as far as what type of technology must be used, whereas the Kansas statute is much more narrow. And then the next regulation is similar to the Missouri statute for APRNs that are in collaborative practice agreements. So here, the mileage limitations or the geographic proximity requirements are not going to apply to assistant physicians and physician assistants collaborative practice agreements if the collaborating physician and the AP or the PA are again using telehealth and it is within a medically underserved area. So the statute required that it be a rural area of need. Here, the regulation for APs and PAs is a medically underserved area. So if those two things aren't met, if they're not using telehealth and it's not within a medically underserved area, then the mileage limitations do apply, and the collaborating physician and the AP or the PA cannot be further than 75 miles by road from one another when providing services. If the assistant physician is using telehealth, then the collaborating physician may conduct the exam via live interactive video. Again, like the statute for APRNs, patient consent still must be obtained, and the parties must still comply with HIPAA. And finally, the final regulation provides the same type of requirements regarding patient consent and HIPAA for collaborative practice agreements with nurses and collaborative practice agreements between physicians specifically and registered nurses and APRNs. So now we have the Missouri statutes and regulations after COVID-19. So now the Missouri statutes are requiring that physicians ensure that they have a properly established physician-patient relationship with the patient before they provide telemedicine services. And there's 3 ways that this can happen, and the last one is what's most relevant here. But first, it can be via in-person encounter with a medical interview and physical exam. So that's probably your general run-of-the-mill how things were done before COVID. The second option is consultation with another physician who has an established relationship with the patient and agrees to participate in the patient care. And then finally, a telemedicine encounter. However, again, the standards of care and the standards of practice must still be followed, even if it is provided via telemedicine. So next we have the ways to establish a physician-patient relationship via telemedicine. So the technology used, so before when they give you that broad definition of telemedicine, here they're giving a little more guidance that the technology must be sufficient to establish an informed diagnosis. So I guess it's not that specific, but it gives a little bit more. And then before providing treatment, the physician must interview the patient, collect the patient's medical history, and perform an examination that's sufficient for the diagnosis and treatment of the patient. So again, basically the type of care that you would provide for inpatient services when you're providing in-person services. So again, the Missouri statute specifies that a questionnaire is not enough to constitute an acceptable medical interview and examination. So Missouri is established in August a statewide telehealth network. And basically what it's going to do is establish forensic examinations of victims of sexual offenses. And why it is relevant here is because it's going to provide telehealth services that will be available 24/7. Okay, so now is a good time to stop. You'll probably be seeing the poll of "Are you still watching?" So you can click yes, or if you're not seeing that, you can go ahead and type in the code that's on the screen to get CE credit. So beginning October 1st, 2021, hospitals are going to have to report these 4 things, but most relevant here is that after July 1st, 2022, hospitals are going to have to report the number of medical providers that are employed or contracted with the hospital who are utilizing the training and telehealth services provided by the statewide telehealth network. Sorry, one second. So beginning January 1st, 2023, or no later than 6 months after the statewide telehealth network is established, hospitals are going to have to do these 3 things. They're going to have to perform the forensic exams. They're going to have to ensure that those providers performing the exams have the training to do so. And if the provider is not a sexual assault nurse examiner or other similarly trained physician or nurse, hospitals in Missouri are going to have to utilize telehealth services during such exams to ensure that guidance and support is provided by a sane or a similarly trained physician or nurse. So finally, we're at our federal requirements before COVID. So Section 1834 of the Social Security Act had 5 requirements that address the geography, location, service, technology, and provider requirements for telehealth. And under these 5 requirements, there was a very low utilization rates, which however got a huge boost after COVID because these requirements were waived, which we will see coming up. So under the Section 1135 waivers, the Secretary of Health and Human Services was given the authority to waive or modify certain Medicare, Medicaid, and Children's Health Insurance Programs requirements. So here the waiver addresses telehealth services. So it waives the requirements that specify the types of eligible practitioners that may bill for their services when furnished via telehealth. So it expanded those healthcare professionals to include those who are eligible to bill Medicare for professional services. And then later, CMS expanded this so that auxiliary personnel can also furnish telehealth services and then bill incident to the services of an eligible billing practitioner. Again, the waiver addressing telehealth, it waives the requirements to the extent that they require the use of video technology when related to telehealth. So now it expands the use to audio only equipment, to furnish services that are described in the codes for audio only telephone evaluation and management services, behavioral health counseling, and educational services. So the next waivers are for hospitals, psychiatric hospitals, and critical access hospitals, which include cancer centers and long-term care hospitals. So this waiver makes it easier for telemedicine services to be furnished to hospital patients through agreements with off-site hospitals between these types of providers listed in the heading. Next, long-term care facilities, skilled nursing facilities, and nursing facilities benefited from some waivers. These waivers waive the requirement that physician practitioners perform in-person visits. Now they're allowing these visits to be conducted via telehealth options. And similarly, in the second waiver, they're waiving the requirement that all physician visits be made by the physician personally. So now physicians can delegate those in-person visits to nurse practitioners, physician assistants, and clinical nurse specialists. And even further, those visits not only have to be done by the physician themselves, but can be provided by these other practitioners via telehealth. Then end-stage renal dialysis facilities also benefited, and it waived the requirement for monthly in-person visits if the patient is stable. And now CMS is recommending that the providers use telehealth to ensure patient safety, especially when they're patients that are in stable condition. And then practitioner locations. This waiver is like the Kansas telemedicine waiver applications. So it allows out-of-state practitioners, it waives the requirement that out-of-state practitioners be licensed in the state where they provide services. However, they must meet 4 conditions. They must be enrolled in the Medicare program. They must possess a valid license to practice in the state that applies to their Medicare enrollment. They must furnish services in a state that is affected by the public health emergency, which at the time, this was like generally everyone. And the practitioner must not be excluded from practice in any way. So now we have slides about going forward. Kansas is currently not under a state of emergency. It ended on June 15th, 2021. However, because Governor Kelly passed Senate Bill 283 for the expanded use of telemedicine, that will last until March 31st, 2022. So for us Kansas providers, we know that we've got about 5.5 more months. And then to operate under that, the Kansas statute. And then Missouri also is, their state of emergency has ended. However, Governor Parson issued what he called a more targeted state of emergency. And it acknowledged the fact that the Missouri's healthcare system could benefit from the emergency provisions. So it kept in place those that were related to telehealth. So under the federal public health emergencies, these are set in 90-day increments, and there are no notice or extension requirements. So HHS last renewed the determination that a PHE exists on July 19th, 2021. So that 90-day increment will end on October 18th, 2021. So that's coming up. And Although President Biden sent letter to the governors stating that the PHE they intend to extend the PHE until 2021, there are no notice or extension requirements, so they do not have to. So our recommendation is to prepare as if the public health emergency is going to end abruptly without notice, because it very well could. So don't expect the temporary telehealth codes to extend past the public health emergency. So this is related to your billing practices. There were 3 categories that were under the proposed rural physician fee schedule. Category 3 is supposed to last until the end of 2023. So we have a solid date for that. But the non-category 3 billing categories, will end at the end of the pandemic, or end of the public health emergency. So we don't know when they're going to end. Could be October 18th, could be the end of the year. We want you to prepare accordingly, as if it could end on October 18th. So document your compliance with the law, document your compliance with the waivers, include it in your patient medical records and in your policies and procedures. Demonstrate that you've gotten the necessary patient consent when providing these telemedicine services. Document the type of technology that you've used to provide these services. Specify, have you used telemedicine or have you used virtual e-visits? Document the location, so the originating site and the distant site where you as a provider were located, and where the patient was located. And then document the start and stop times for when those telemedicine services were provided. Make sure your business associate agreements are in place with vendors. I'll talk about it a little more later, but the leniency will likely be ending soon. Conduct security risk assessments over the technology that you use. So when you're specifying in your patient medical records and policies and procedures that you've used certain technology, it would be great to back that up with security risk assessments that specify why you are prepared to protect the patient information with that technology. Plan for a blend of services and emergency services, as well as outsourcing options. Plan for technology that might even be allowed after the public health emergency. And remember that even though you provided these services via telemedicine, the patient-provider relationship still exists. So you have obligations regarding patient abandonment, continuity of care, and you don't want to run into issues with inducement problems. So you can no longer provide these services for free, and you need to make sure that you communicate this with your patients and that you document this communication. Again, update patient consents, whether or not you will be providing telemedicine options. Review your coding obligations. Keep up to date with the CMS frequently asked questions. That provides good guidance for how to navigate, and we anticipate that they will issue those FAQs after the PHE has ended. Review interim final rules and make your voice heard. So call your state representatives, let them know how telemedicine has benefited your practice and your patients, and respond to CMS's request for comment, because they do a pretty good job of staying up to date with how this all affected you. So things that you can anticipate are going to end. The OIG payment requirements, currently they are using their enforcement discretion to not enforce, but we foresee that this is going to, it's not going to last forever. The Ryan-Haight Act exceptions, which allowed physicians to prescribe controlled substances via telemedicine without in-person exams. This is likely to end as well. And like I said before, leniency with not having BAAs in place with vendors, this is likely to come to an end too. So make sure you have your ducks in a row. And then things that we foresee that could begin following the end of the public health emergency, the Connect for Health Act of 2021. This is this eliminates the geographic restriction under the federal requirements for telehealth, and it gives more flexibility for telehealth practices. It has strong bipartisan support. And then the Telemental Health Improvement Act, it requires that private health insurance plans that cover in-person mental health or substance use disorder services, that they cover such services on equal terms via telehealth. So those are the things that you have on the horizon, and that is the end of my presentation.